Hello, everybody, and welcome to another episode of Mind Matters, Navigating Head Injuries and Concussions. I'm your host, Kylie Como. I'm the legal nurse consultant here at Shane Smith Law, and today I'm here again with Dr. Gilbert Mbeo from the Brain, Spine, and Pain Institute. Dr. Mbeo, it's a pleasure to see you again.
Thank you for having me. Great to be here.
So, of course, as our watchers, our viewers know, and for those that don't, our focus here is to discuss all things brain injury and other related topics. So here we go. Let's get into it. Dr. Mbeo, first question, can you kind of give us just a broad overview, really, of what a post-traumatic headache is and why that matters to us?
In the context of a brain injury, one of the most common complaints that individuals will come in to see a neurologist with is this post-traumatic headache. So quite a significant matter and worth discussing. When we look at headaches, typically you see patients come in with, we call them phenotypes, different presentations of this post-traumatic headache. These phenotypes, these presentations sometimes mimic common headache syndromes. Sometimes these headaches look like migraine. In fact, take on that migraine-like phenotype in the setting of having been triggered by a traumatic brain injury. Sometimes these headaches will take on a phenotype of what we call a tension-type headache. So different phenotypes of headaches will be triggered by this traumatic brain injury and quite common as a complication. As a neurologist that sees a lot of patients with traumatic brain injury, my goodness, my TBI clinic will be dedicated to trying to help understand and help treat post-traumatic headaches.
Yeah, I understand. So being quite common, that's good to know. I was not necessarily aware of how common that was. So how is it particularly challenging for you to treat them?
So the challenge in treating these post-traumatic headaches comes from the fact that post-traumatic headaches are many presentations, so varied presentations. So important that as a treating physician that we take time to really understand the nuances around the headache. When did it begin? When does it begin? What symptoms are associated? Are there any triggers? Are there any aggravating, alleviating factors and things of that nature? So really taking a nuanced history is necessary. But the other challenge in treating these headaches is the fact that we don't have many treatments, many standardized treatments for post-traumatic headache. And I give an example. So migraine, for example, has years of clinically backed data behind treatments we can use to alleviate migraine. So a cluster headache would be another example of a headache syndrome that again has data behind approaches we can use to try and help diagnose and treat cluster headache. But in the post-traumatic headache situation, unfortunately, we don't have very standardized, protocolized manner. And so each clinician ends up needing to rely on their clinical acumen and perhaps their tool belt that would be utilized in our other headache syndrome. A good opportunity for research is certainly looking into options, pharmacologic options, interventional options for these challenging to diagnose and challenging to treat headaches.
So how do most of these post-traumatic headaches kind of typically present? And I heard you talking about the phenotypes, are there certain ones that may dominate?
Good question. So we could look at these post-traumatic headaches in terms of timeline. So let's talk classification of these post-traumatic headaches. So how to recognize them, how to classify them. We could look at the acute post-traumatic headache. And typically the onset of the acute post-traumatic headache is going to be within 7 days. But typically we will call it acute because with that acute onset, the resolution of the headache would be within weeks to 3 months. So any headache that acutely develops after a traumatic brain injury and then has a resolution time of about 3 months or less than 3 months, we will classify as an acute post-traumatic headache. Now, unfortunately, there does exist a certain subset of patients that will unfortunately be afflicted with a persistent post-traumatic headache. So we go now from that acute presentation to a more prolonged course, anything beyond 3 months. And truly, in a traumatic brain injury clinic, not unusual to see patients come in within that subset. So these are individuals that have suffered a concussion a year and certainly years. I see patients years after the concussion who now live with this persistent post-traumatic headache. And just by classification, anything that's going to be beyond 3 months would be that persistent post-traumatic headache. So we've talked acute and we've talked persistent post-traumatic headache. As we think through phenotype just helps us understand what is that presentation? What does that headache look mostly like? So when I say phenotype, the most common way that these post-traumatic headaches will behave, will be with that migraine phenotype. Certainly when I'm seeing patients weeks, months, even years after the inciting injury, the headache starts to evolve into taking on certain behaviors that we call phenotype, certain behaviors that could mimic other headache syndromes. The migraine phenotype is quite common. How does that sound? It's going to be that typically unilateral headache, typically throbbing headache, typically associated what we call photophobia and phonophobia. So bright light and loud noises aggravating that headache. Sometimes in that migraine phenotype, these patients with a post-traumatic headache will talk about, I'll have a warning. I know when it's about to happen. My vision gets blurry. I might see flashes of light. We call that an aura. So again, just taking on that migraine type of behavior. Certain triggers will be identified. Smells, foods, certain situations, lack of sleep or sleep deprivation or increased stress or situations with increased stress. So really taking on that, what we call the migraine as a phenotype. And that's important. So really understanding the phenotype when we take a history in this post-traumatic headache, really understanding the phenotype helps direct us towards what are some of our useful treatment options. The other phenotype that can be pretty common in this post-traumatic headache setting is that tension type headache phenotype, that band-like feeling wrapping around my head, that really tight feeling that one's going to feel maybe from the back of the head to the vertex. So that tension type headache phenotype, worse as the day goes by, worse in stressful days and things of that nature. So let's talk broadly, that full list of the phenotypes, but the more common ones are the migraine-like phenotype, and like I said, that presents with a lot of migrainous features, and really important to delineate because that helps us come up with therapies for this headache syndrome. And then there's the tension-type headache phenotype, and so those are the ones that in a concussion clinic I'd typically encounter a lot. And understanding the phenotype, really taking time to take a careful history, conduct an examination, and things of that nature really helps us come up with treatment options. So the phenotype is quite important.
That's very interesting. I'd like to dig into the kind of the management and treatment here in a little bit. So one thing that got me thinking about, and we certainly do, just working for Shane Smith Law, a lot of our clients come in with head injuries and whatnot, and those two phenotypes, that migraine and that tension type are certainly the ones we see in our clients far more frequently than anything else. So you nailed that one for sure. But one thing it also got me thinking of, a lot of these clients, and I'm sure your patients, same thing, have either pre-existing or a new onset things like sleep disturbance or other, like anxiety, depression. How do those sorts of things influence, the course of the way you treat that post-traumatic headache?
Amazing question. And that's a great observation. Many of these patients in the setting of a traumatic brain injury, it's important as we take a history, as we understand lifestyle factors, really important to understand some of these comorbidities. So these co-occurring issues, both lifestyle, medication, medical related comorbidity, really important to understand comorbidities. And some of the things that stand out in this subset of patients would be sleep disturbances. So not unusual, again, in the setting of a traumatic brain injury. Unfortunately, that disrupted sleep-wake cycle contributes to this everlasting cycle of headaches and poor sleep, headaches, cognitive changes, and many, many other systemic risks that puts these patients to. Anxiety disorder. So again, a concussive injury is more than just that force that's delivered to the brain. It's beyond that. So it's at least part of it. The trigger is that force that's delivered to the brain. However, that force delivered to the brain will trigger a neurometabolic cascade that can last days, weeks, months, and years. And part of the things that can happen is disruption in neurotransmitters. And in that neurotransmitter disruption, not unusual to see as a comorbidity, heightened anxiety, feelings of PTSD. Let's not forget that very same trigger in these traumatic brain injured patients, that many times that same trigger, that same inciting event for the traumatic brain injury, not unusual for that to be a daily re-exposure. Suppose all this happened in the setting of an automobile accident. Many of these individuals day to day still need to get into an automobile and live their day-to-day life re-experiencing that traumatic event, driving down that very same highway where all this happened. So depression, also not unusual to see as a comorbidity. Cognitive changes quite important as a comorbidity. Now, really understanding these comorbidities is helpful because it helps us tailor therapy to each individual. I'd be thinking about perhaps finding a medication that could help with that comorbidity, a medication that would help with sleep, but also could help with preventing these frequent headaches that they're experiencing. A patient that came in with cognitive changes, for example, would be one where perhaps certain medicines that can have an adverse cognitive outcome. So I'll give an example of topiramate. So it's one of our go-to medicines in migraine therapy, topiramate. Quite helpful in many patients, but unfortunately can worsen cognitive symptoms. So somebody that came in with a traumatic brain injury, with a headache, and had cognitive symptoms, perhaps topiramate would not be the most ideal option. So again, just choosing that individualized therapy. Someone that came in, for example, with heightened anxiety, feelings of PTSD, for example, along with the headache, perhaps a medication such as venlafaxine or Effexor. So an effective medicine for anxiety and depression-related symptomatology, but also quite effective in preventing headaches, might be a reasonable option in such an individual. Same thing, coexisting depression, as we take that careful history, could help us tailor medication. So a medication that helps with depression-related symptoms and helps prevent headaches. So really understanding comorbidities, which exist at really high rate, would be quite useful as we tailor our therapy for these patients.
And you mentioned medications a few times throughout there. Certainly medication management is one of the primary ways. I'm sure that you and your team, manage some of these along with some of the other, cognitive therapies, whatnot. But medication like polypharmacy or even medication overuse is a huge issue these days, especially in some of our older clientele, patient population. They're on multiple medications. So knowing that history is key. How does that complicate your treatment of those things?
Absolutely. So it's another great question. As we think through polypharmacy, especially older individuals will come in with, many times a cocktail of medications that are to address, different systemic issues, maybe a blood pressure medication here or 2 blood pressure medications, a medication to try help with cardiac function, a medication to help with maybe reducing the incidence or occurrence of cardiac blockage, maybe aspirin, Plavix, or a blood thinning medicine on top of many other medicines, something for neuropathic pain, for example. So really important as one's taking that history to understand what else are you taking? What else are you taking? Because the issue of polypharmacy, it truly is, it's real. And medication interactions and how these medications affect our metabolism and how one medication affects our metabolic pathways that could affect levels of another medication. Really important as we tailor treatment for these individuals. So polypharmacy certainly is a concern and one of the things we need to take a careful history about. You bring up another point. So medication overuse and perhaps self-induced or self-medication and that self-inflicted medication overuse, but also many times we are part of medication overuse, we as clinicians. So medication overuse. Now, not unusual to have this individual who has now been afflicted with a new daily persistent headache, this headache that just will not go away. Their new normal is a day or days and nights afflicted with different types of headaches. So a daily headache that just will not relent. Not unusual for these individuals in that thought of self-medication. What can I do for myself? And not unusual for them to be on maybe a cocktail of medications, or we could talk about maybe one particular, maybe a non-steroidal anti-inflammatory medicine, which now they take 2, 3, 4, 5, I've seen 6 times a day and in super therapeutic doses. So we call that, again, that medication overuse, which on its own has many issues. One issue is they get into a cycle of this daily headache that is now worsened by medication overuse. These headaches actually get worse. And then whenever the medication levels dip, so whenever they do not take the medication, they have these rebound pretty severe headaches. So medication overuse is quite real in these patients. So as you take that headache history, really carefully try to understand. I always try to understand what other medicines are you taking? Help me understand what your medication regimen is. How do you take XYZ medication? And then we're able to parse out that medication overuse as part of what's contributing to this vicious headache cycle. The other part becomes medication overuse starts to expose them to systemic side effects. So issues related to their gastrointestinal tract, so ulcers and gastrointestinal erosions because of the effects of some of these medicines. Liver disease, so just injury to the liver that can progress to many other places, again, just because of overexposure to certain medications. Kidney issues, again, because of the adverse effects of some of these overused medications on organs like the kidney. So medication overuse is real. It's quite an issue in these patients. And unfortunately, it's in that attempt to self-medicate out of this vicious cycle of daily headaches and nightly headaches. And so as we tailor therapy, the goal is also to try and help taper down some of these overused medications and then really find reasonable alternatives for these overused medications. Because
that's an amazing rundown. Yeah. And even throw on top of that, so many people are now using supplements, over the counters that often don't get worked into these medication reconciliations when they go to a doctor's office or a hospital. Do you find yourself running into issues with certain supplements, or do you see that much?
Many supplements that have different systemic effects, metabolic effects, can affect how medications get broken down and the levels of different medications. And these are, call them in quotes, harmless herbal supplements or harmless vitamin supplements and things of that nature with a good intention might have effects on our cerebral, intracranial blood vessels and some not unusual to have effects of changing blood vessel tone, especially in the brain. So narrowing or what we call dilatation. So again, having an effect on either triggering headaches or worsening headaches. So really important to understand that. And then certainly we've talked about supplement medication interactions. We don't think much about that, but certainly something to be aware of. They can affect metabolism of our medicines. They can on their own cause headaches. They can affect other organs, including the brain, and worsen their headache syndromes.
So for all you folks listening, make sure you're giving your docs all the meds you're on, including those supplements. So Dr. Mbeo, what would you say then, is there a gold standard or recommended approach to managing treatments to these headache phenotypes?
So a good way to look at it is perhaps taking a phenotypic approach, history taking, to understand what are the triggers, what is the frequency, what is the intensity, where is this headache located? Is it the side of the head? Is it the front of the head? Is it above the eye? Is it behind the head? So really understanding the phenotype help match phenotype to our treatment options. Now, going further, how I look at it along with phenotype is perhaps the acute headache. So this new onset post-concussion headache that's perhaps we're days into this event having occurred. I've been having this headache all day is what they'll tell me. So all day since that accident, since that whiplash, or since I struck my head against the dashboard or against the seat or the window or things of that nature. So that acute post-traumatic headache, I would typically look at the use of non-steroidal anti-inflammatory medicine. So again, just a typical go-to would be NSAIDs, being careful about medication overuse. But again, NSAIDs have quite a use in that. There's a class of medications called the triptans. And I'll give just one example, sumatriptan. In this acute, early, we're not late into the cycle of relentless headaches. Triptans also have some use in these patients. So I'll go patient by patient and then case by case, and certainly in the acute situation, might try to see if we can get by with a tincture of thyme and perhaps non-steroidal anti-inflammatories. And then maybe in some patients, appropriately selected, triptans would be an option. I'll give a little caveat while we're in that acute post-traumatic headache period. So a little caveat is you really want to do the best you can as you take a history and conduct an exam. You want to rule out the red flags of a headache. So this post-traumatic headache in certain individuals could be simply just a post-traumatic headache, and with all the behaviors, with all the features of a post-traumatic headache. We must be aware though that this post-traumatic headache could be a signal to bad things happening in the brain. So as you take a history and understand circumstances around it, really carefully conduct an examination, you really want to identify what we call the red flags. So sudden onset, worst headache of life. Those are some of those red flags. So a severe headache. Focal neurologic deficits. So when I say focal neurologic deficits, it's along with the headache, Dr. Mbeo, I have my right arm feels a little heavier or feels weak, or I have a clumsy feeling in my right hand, or outright weakness in that right hand. My face is a little droopier, or family members might describe that, or they might describe a droopy eyelid. So really carefully trying to understand these acute changes. Other focal neurologic deficits could be speech and language changes, ever since that traumatic brain injury, ever since that concussion, I have had the headache, but my talking is a little off. Slurred speech and difficulty expressing speech, difficulty understanding speech. Or ever since the headache, they've been acting a little more confused than they usually would. Certainly, all these are post-concussion symptoms, but as one carefully takes a history and carefully tries to conduct a neurologic exam to tease them out, these focal neurologic deficits, these red flags could be signals that something sinister, so addition to the traumatic brain injury, is going on. A bleed in the brain. We call that type of bleed, the most common one in that setting, a subdural hematoma. So a subtle bleed on the surface of the brain that sometimes can get larger and starts to compress the brain. It could be a bleed in the substance of the brain. We call it an intraparenchymal bleed, and a few other things that could be signaled by what we call the red flag signs.
Yeah, that's critical to call out. You describing stroke-like symptoms. Definitely not something to be played with. Not something to try to be medicated away. Definitely emergency situation. So glad to hear you guys scream pretty aggressively for that, obviously. But for those of us that are listening that maybe at home or have a loved one suffering, definitely be watching out for those things. And if you notice those, that is an immediate call to 911. So that is a great call out. Very important. Okay, everybody, that's going to do it for another episode of Mind Matters, Navigating Head Injuries and Concussions. Again, I'd love to extend our gratitude to Dr. Mbeo for joining us today and sharing his expansive knowledge and expertise with us. I hope that our audience has enjoyed being a part of this really fascinating discussion as much as I've had, and walking away with a deeper understanding of some of the resources and cutting-edge treatments being used to diagnose and treat brain injury. Please don't forget to hit the like button and subscribe to our channel to keep up with our latest and greatest content, and leave us a comment today to let us know what you thought of our conversation. And as always, remember, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.